Thank you for this opportunity for us. I'm presenting on behalf of Ali Esparham, who could not be here. I have nothing to disclose. Global trends indicate there was some increase in opioid use. CDC estimated about 2 million Americans had opioid use disorder in 2016, and some global studies showed millions of people and hundreds of thousands deaths from the opioids. In the US in 2017, we had the emergency announcement by the public health for this specific problem. Back to obesity, you all know more than 40% of obesity is 9% severe obesity in 2017 based on CDC. Obesity is notably related to pain disorders because of different factors, biomechanical, inflammatory mediators, and lifestyle factors. Patients with obesity, morbid obesity, may have 4 times more pain problems, and some prevalence of opioid use in this group of patients is way more than the control groups, 8 to 15% versus 3%. So just a quick look on prior studies. Ontario Bariatric, 12% opioid use before the surgery and was associated with prolonged length of stay and complications. Swedish, same thing, 17% had at least one prescription, 4% were chronic, and again was associated with high risk after surgery, complication, length of stay, readmission, reoperation, and the higher dose of opioid was associated with higher risk stepwise. So in this study, we tried to use national inpatient sample, the US national data, to explore this problem, and bariatric surgery. HCOP produced NIS. NIS basically is 7 million records per year, is a 20% sample of the US all admissions. Opioid use disorder has been defined by DSM-4. Previously, it was as abuse or dependence. We used the code of ICD-10 F11, which includes all use, abuse, and dependence, which is kind of a challenge of all of these studies. We used data from 16 to 20 adult patients, included the sleeve bypass and duodenal switch codes as ICD-10 procedure codes. We also included DRG codes to make sure those are all bariatric. Patients or records with missing data on demographic specifically, we excluded that, and divided our patients to opioid disorder versus not. Primary outcome, we looked at all the complications, so we pulled all the ICD codes for all possible complications and made new variables. Also looked at the length of a stay and charges based on this database. We used the SPSS and also R for a matched analysis. Each case of opioid use disorder was matched with another from control group based on all demographic and comorbidities, and all these baselines try to be matched together. So 34 million records, 164,000 bariatric, mostly sleeve, 70%. After weighted analysis, we could find 2,200 opioid-related disorder, which is very low number, it's 0.3%. In the univariate analysis, the opioid disorder patients had significantly higher age, more male patients, more Medicare and Medicaid patients compared to private insurance and others, more white, and more gastric bypass and duodenal switch versus a sleeve gastrectomy. Also, the opioid patients had more comorbidities, as you see in the last line, coronary artery disease and kidney disease and all those. Patient with diabetes also had more opioid-related disorder, BMI above 50 as well. In terms of socioeconomic, we looked at the median household income, but we could not find any difference in different groups. So in another word, again, higher age, more men, more bypass and switch, and more diabetic, more BMI above 50. These had more opioid use disorder recorded. Again, on the race, white, and the insurance, more Medicare, Medicaid, and on the household income, no difference. We did a propensity score matching, 1-to-1. We could match 2,175 patients opioid-related disorder with the same number of others. After matching, all the disparities was not significant except the type of surgery and diabetes. Because of this, we continued with, again, multivariate regression analysis to include all of those factors. So in general, the ones with opioid-related disorders, this factor was independently associated with increased odds of all complications when we included all those complication ICD codes. Specifically, we could show with acute renal failure, pulmonary complications, nausea, vomiting after surgery, bleeding, and mechanical ventilation. Length of stay also was higher in this group, and also the charges was 69,000 versus 63,000, significantly higher. Just same data, but the last row you can see, we try to see if the mortality is different, but in this 2,000 group, the numbers was less than 10, and based on NIS data, we could not report, and also it was not significant. So conclusion is a little bit challenging. I think the main conclusion is that opioid-related disorders may not be documented appropriately in medical records. Basically, in this database, the registrar goes to our discharge summaries and op reports and codes based on those. Because of that, administrative databases underreport opioid-related disorders, and any research coming from these databases should be interpreted cautiously. But back to the results we found, which was similar to other previous two studies, is opioid use seems to be associated with higher rate of complications after bariatric surgery, with a longer length of stay and charges. And this group of patients may need to be optimized more aggressively beforehand and be monitored closely afterwards. But specifically, I think in this topic, we have to go back to the single center research and basically in-depth review to see what are the cause of complications, what causing all those specific things that we found. Is it more bleeding, more pain control, pulmonary, and what are the areas of improvement and intervention we can do? Thank you.